At the completion of this lecture, you should be able to answer the following objectives. HRCT is a technique designed to maximize spatial resolution, thin collimation, and reconstruction with a high-frequency algorithm. Additional techniques are illustrated in the HRCT Expert found in the practice section of this site. CT has two advantages over chest radiography in the evaluation of diffuse lung disease: lack of summation and the inherent high contrast sensitivity of CT. The secondary pulmonary lobule is a variable-sized, incompletely septated unit of lung distal to the terminal bronchiole. The lobule is composed of 5 to 17 acini, which are supplied by respiratory bronchioles. Terminal bronchioles are visible at CT, respiratory bronchioles are not. Unfortunately, many disease processes originate in the respiratory bronchioles. Click on acini to view. In this dried lung specimen, the core structures are composed of the terminal arteriole, which has a thick wall, and the adjacent terminal bronchiole. Note that the rest of the lobule is featureless, with a few scattered dots and short lines. The respiratory bronchioles are not visible. In this fresh-cut inflated lung, use the cursor to highlight the bronchovascular bundle and note the overall size of the secondary pulmonary lobule. Also note the anthracotic pigment, which is located in and around the respiratory bronchioles. The respiratory bronchioles are not visible. Note that the centriacinar portion of the lobule is off-center with respect to the bronchovascular bundle. In this normal inflated histologic section, again note how large the terminal bronchiole is compared to the rest of the lobule. A vein is present in the periphery of the lobule in the region of the septa. There are hundreds of known diseases that may produce diffuse lung disease. However, only a handful account for the majority of diseases seen in clinical practice. In London, these 6 diseases account for 80% of diagnoses, and in Vancouver, 5 diseases account for 83%. Compare the lists. The difference reflects the geographic location and referral emphasis of the hospitals, as well as the different naming conventions for the same disease. Taking a cue from Louis, I've combined the two lists with my own experience into a list of 10 disorders. This will account for over 90% of what will be seen in clinical practice. The features of sarcoid include symmetric adenopathy and a distribution which favors the mid to upper lung zones. Occasionally, multiple airspace masses which contain air bronchograms are seen. Peribronchial central fibrosis will be illustrated shortly. At HRCT, granulomas cluster in the lymphatics, so that nodules will be found along blood vessels, bronchi, and in the septa. Note the distribution in the mid and upper lung zones, particularly the right upper lobe, at chest radiography. Many of these diseases have a proclivity for the right upper lobe. At CT, nodules are clustered around blood vessels, are prominent in the centriacinar portion of the lobule, and are visible along the edge of the lung in the periphery of the lobule. Sarcoid tends to cut a swath through the lung from the hilum to the lung periphery. This is central peribronchial fibrosis. Go back to the previous slide and note a more subtle swath through the lung. Here's a way to remember. Think of Sherman's March to the Sea as a manifestation of sarcoid. Similar to sarcoid, EG favors the mid to upper lung zones. Instead of lymphatic nodules, the nodules in EG are related to airways and spare the periphery of the lung. The natural history is the progression from nodules to thin-walled cysts, which in turn coalesce into bizarre shapes. Note the severity in the upper lung, especially the right upper lobe, and the bizarre-shaped cysts at CT. Patient presented with a right spontaneous pneumothorax treated with a chest tube. Multiple ground glass centriacinar nodules spare the lung periphery. In some cases, the nodules may have a starfish shape with 3 to 5 projections, a characteristic also seen at pathology. Click on the starfish to highlight the nodule. Usual interstitial pneumonitis, also known as IPF, tends to primarily involve the periphery of the lower lung zones. At HRCT, a combination of ground glass opacities, intralobular lines, honeycombing, and traction bronchiectasis are the hallmarks of this disorder. Ground glass opacities may represent active alveolitis, but may represent atelectasis or fibrosis. One way to conceptualize IPF is the shrinkage and simplification of the normal polyhedral secondary pulmonary lobule. Also characteristic is a time sequence similar to MS, that is, multiple lesions separated both in space and time. For example, islands of honeycombing are seen adjacent to other areas which are normal. In the right upper lobe is an area of consolidation, reflecting active disease. Note the predilection for the lung periphery. The basilar predominance and volume loss are strikingly demonstrated in the sagittal lung section. Note at close-up the variable size of the cysts seen with honeycombing. The same pattern and distribution of disease is seen in the collagen vascular diseases. Note the dilated, air-filled esophagus. Not all patients with collagen vascular disease will have a histologic pattern of UIP. In some, the pathology represents nonspecific interstitial pneumonitis. The distribution in lymphangitic tumor is variable. However, a characteristic feature is the sparing of a lobe or even a lung. Similar to sarcoid, the nodules involve the lymphatics. In general, the central bronchovascular structures are more severely involved than the periphery of the lobule. In this example, lymphangitic tumor involved only the right middle lobe. Note the irregular thickening of both the septa and the bronchovascular bundles. This pathologic specimen nicely demonstrates the irregular thickening of the septa. Lymphatics extend only as far as the terminal bronchiole, and then are again seen in the septa and along the pulmonary veins. A disease process that involves only the lymphatics will spare the acinus. Click on the lymphatic-free zone. While one doesn't normally consider edema in the category of diffuse lung disease, it is surprising how often patients are referred for end-stage fibrosis, which turns out to be reversible pulmonary edema. Note the large heart, ground glass opacities, and the prominent septa. In this patient, the bases were more involved as the patient was sitting upright prior to placement on the CT table. If the patient had been bedridden, the dependent lung would have been more involved. The sparing of multiple lobules, as seen here, is also characteristic. The reasons for this are unknown. In contrast to lymphangitic tumor, the septa are smooth, not beaded. Asbestosis is similar to UIP in distribution. Asbestos fibers deposit in the respiratory bronchioles, and early findings reflect fibrosis in and around the respiratory bronchioles. Note the diaphragmatic plaque and the subtle interstitial thickening, which will be better shown on the next slide. Both short and long lines are demonstrated. Short lines extend from the region of the respiratory bronchiole to the periphery of the lung. Note the prominent parenchymal bands in this example. Similar to sarcoid and EG, silicosis primarily involves the upper lobes, particularly the right. Nodules may aggregate into large masses known as progressive massive fibrosis. Adenopathy is also common, which may have eggshell calcification. Note the severity in the upper lung, especially the right. Nodules are concentrated primarily in lymphatics and will be associated with both the periphery and centri-acinar portions of the lobule. Cole-Worker's pneumoconiosis is similar to silica. However, the cold macule is usually centered in the respiratory bronchiole and may spare the periphery of the lung. Note the absence of nodules in the lung periphery. Extrinsic allergic alveolitis is also known as hypersensitivity pneumonitis or farmer's lung. General predilection is for the mid-lungs. Ground glass airspace nodules are characteristic. The disease is clinically divided into acute, subacute, and chronic phases. Patients with chronic disease may have honeycombing and fibrosis in a pattern similar to UIP. However, the honeycombing generally spares the costophrenic angles. Note the centri-acinar airway nodules, primarily involving the mid-lungs in this patient with farmer's lung. In contrast to the profusion within the lobule, the periphery of the lobule is relatively spared. Remember, the airspace nodules of EG, which is due to cigarette smoking, or the airspace nodules of hypersensitivity pneumonitis and Cole-Worker's pneumoconiosis, which are due to inhaled dusts, are similar in that the dust particles deposit in the respiratory bronchioles in the centri-acinar portion of the lobule. This is the same location as the deposition of anthracotic pigment as seen in this pathologic specimen. Last but not least is drugs. Drugs may cause nearly any pattern. A pattern of edema is common with cytotoxic agents. NSIP is also common with the chemotherapeutic agents. A Boop-like reaction is seen with many drugs. Note that a single drug may cause more than one pattern. An allergic pattern is classic for methotrexate. Methotrexate is also known for its negative re-challenge. That is, the drug can be stopped and started again, and the patient may not have a recurrence. I hope you have enjoyed this lecture. Here's an aid to help you remember the 10 usual suspects. Substitute histiocytosis for EG, use T for tumor, failure for edema, and environment for the inorganic and organic dusts. Now, what does that spell?